Our last lecture will be delivered by Dr. Badr Al-Mustafa, and Dr. Badr is a consultant family medicine, senior consultant family medicine and chronic care, clinical hypertension specialist in Khatib Primary Health Care, General Secretary of the Saudi Hypertension Society, and he is also the Middle East representative of the World Hypertension League.
If you make it lower, yes. If you make it lower,
yeah. It's
Bismillah ar-Rahman ar-Rahim. Shall I make it lower from here? Yes, please. Assalamu alaikum wa rahmatullahi wa barakatuh jami'an. It's my pleasure to be with you today. I've met most of you maybe yesterday. However, I may be talking about a child who is hypertensive. I may be talking about a mother who is having a high blood pressure. But now I'm talking about a father, a grandfather, which is almost a must. One of them is having high blood pressure. So this is not our patients. This is my father or grandfather, my mother or my grandmother. There is no, I guess, a home in Saudi Arabia is having no single hypertensive father or grandparent. So we need to give them some care. Unfortunately, once I'm retired, everybody is looking to me as if I'm just waiting for graveyard. Is there any chance to live more productively? We need to think of that. We know at least many of the examples who are very productive at the age of 70, 75. I know much more productive people at even an age reaching the 80. How to take care after them? Because we are neglecting them as a family, and we are maybe neglecting them as well as a service provider. I've been requested to be very short at the end of this morning session. However, this guy, he is almost 80 plus. He is functioning independently. Imagine that if he is losing his function, who will take care after him? However, he is having some problems in his heart, atrial fibrillation, some neurological problems, some lacunar infarctions. This doesn't mean that he cannot function. However, his blood pressure is slightly high. Shall we treat this or not? Shall we approach it? And if so, which medication I'm going to use? And I wonder, is there any evidence that these patients will really benefit from the intervention that I'll be giving to this patient or not? So I wonder if I can really cover all that in these 15 minutes. Let's try. We have still much more queries for high blood pressure treatment in an elderly. It's not only the high BP, but is it really hypertension? So what is the definition of hypertension in this age group? More or less, who is elderly? Is it the 65? Or is it the 75 plus? Or is it the 80 plus? Is it the biological elderly, biological age? Or is it the chronological age? Really, we need, all these are questions yet need to be answered. We know 50s who looks like 80s, but we know 70s and 80s who just look like 60s. So is it the chronological, or is it the functional or the biological? This has to be considered as well. There is one very vital issue in the hypertension management. This slide, by the way, concludes all my talk. And I've been requested to make it short. Maybe I'll just stick to 1 or 2 slides. I'll miss the other 30. So please be patient with me. Dr. Abdul Hamid Hassan, I guess this afternoon, will go to a very vital issue in blood pressure measurement, in blood pressure treatment and management, which is blood pressure measurement. Which blood pressure measurement device I have to use? If it is okay for everybody, definitely it is not okay for the kids. Definitely it is totally different for the elderly adults. So we have to make care of that. In addition to that, there is no one hypertensive elderly will present with high blood pressure only. We have multiple of comorbidities. So how to treat it? What medication I'm going to use? Is there a chance that there will be a secondary cause? Because we all know that high blood pressure in below 30, there is a chance to have a secondary cause for his high blood pressure. But almost it is the same if the patient is presented to me at age of 70 plus with high blood pressure. This high blood pressure may be a secondary to another organic problem that I have to pay attention to. We are not treating only high blood pressure, but we are having a geriatric syndrome. What is geriatric syndrome? I'm facing with many other problems, disabilities, comprehensions, understanding, take care of himself, Alzheimer's maybe disease, some urinary other problems that he's facing. All these I have to put in mind. So it is really difficult to have a specialized clinic in hypertension to treat hypertension. It needs a real generalized clinic that they are specialized in the geriatric people rather than to be specialized in hypertension. Is there any place for other preventive medications such like a statin or aspirin? Because the evidences for these medications are yet need to be waited for multiple of years to see that they are really effective. So what about the 70s? Shall I put them on a statin or aspirin? This has to be taken with a very crucial issue. This is an area we are missing a lot. How to monitor these patients? It's just only to measure blood pressure, how to measure it, how to make sure that he is reaching his target BB. If I really have defined it well, this has to be taken care of. I'll miss many of the slides for the purpose of time. However, we need to recall one fact that we may be knowing. What is that? If I've lived to 65, I have a big chance then to live to 10 more years. But if I've reached to even 80s, there is still more chance to have 7 more years to live. So if I'm facing a patient or a person who has already reached 65, then he is having in a good health, then there is a chance to live for more 20 years. And if I've met him at 75, there is still a chance for more than 10 years to live. And if it is at 80, there is still 5 to 7 years to live if he is healthy enough at that age. This means that I'm having really a chance to make the quality of life of the coming years better, not to leave it for comorbidities to come in. And just to flag up. Let's concentrate a little bit about how far they will benefit of treatment or not. Let's see a few of them. I'll make myself very selective in my, let's just put an eye on this. Many will argue about the blood pressure target that I need to go down with my patients. And you will see how far the cardiovascular complications will rise once I am 140 plus systolic. And if I am less, oh yes, if I am just below 70, that's great. I may be fine to reach, but once I'm going If I'm just 75 or plus, there is a chance to have not the lower the better, but the lower will be the worse if I get below 130. So a very cautious approach has to be given to our elderly once they are around 70 years plus of age to go below 130. This is very crucial, I have to put in mind. We'll go just little about the quality of life in our patients. These are the 5 or 6 columns that we are usually following in geriatric patients. We are following in geriatric patients not only physical but as well mobility, self-care, doing the usual activities and so. Are they really different if the patient is having no disease, having hypertension only, or hypertension with comorbidities? And let's see that those who are having no hypertension, they are scoring much better than having hypertension alone or hypertension with comorbidities. So we need really much that our patient, if they are not hypertensive, to prevent hypertension. And if they are hypertensive, they do really benefit of decreasing the chance of having cardiovascular complications in terms of what? Not only blood pressure target. We are not targeting in treating geriatric patients blood pressure, please. We are targeting as well the whole health, which are these elements and which we need to keep it in our fathers, mothers, grandparents as well. Let's see, will really lifestyle changes, modifications affect the parent, the elderly parent? الكل بيقول كبير في السن راحت عليه، صغير ما عليه بتمرن وبروح وباجي ينفع. But will it really change our elderly patients? Let's see how far this will affect. Oh yes, we are having a lot of evidences. Salt restrictions, elderly are the most of benefit, are the most to benefit of salt restrictions in terms of blood pressure. So why not? So this is great for us rather than to use medications. What about doing exercise? Will our patients, elderly, will really benefit of exercise? Oh yes, you can see how far it may decrease. These are multiple of studies have been done which have been shown that we may decrease it by something around 5 to 10 millimeters of mercury by doing aerobic exercise. Why not to do it for the elderly? To take an overview in the last few minutes, we are facing high blood pressure. 70 of them, they are in the elderly age group. So we need to know not only the pediatric or the adult, we mainly need to know how to treat high blood pressure in the elderly age group. We are having one more issue. White coat effect is more. This means that really we cannot rely on the office-based blood pressure measurement in diagnosing, in labeling, and defining hypertension in our elderly. We need to have some other modalities. I hope Dr. Abdul Hamid Hassan will cover that in the afternoon. We are having a poor adherence to medication. Sabah al-Yom, Dr. Korabi has mentioned a patient with multiple medications with just a poor adherence to medications. We all may be poor in pharmacokinetics. And we know that with polypharmacy, you cannot really just go like that. Not only with the overlap with other medications, but as well with other foods and so on. In addition to that, the patients are at increased risk of hypertension, of hypotension. Postural symptoms are a lot, much more, and this will make the patient prone to falls will make their life disaster. A fall, a femur fracture, pelvis fracture is a disaster for an elderly. We have to put a mind of that. We need to treat our patient, but not to treat the blood pressure levels. Really, I need to stop here maybe. Dr. Ghalib, how many minutes I'm having? Oh, great. Then I need to go beyond. This is an issue. The blood pressure measurement in elderly has to be done in multiple positions. We need to measure the blood pressure in sitting, and as well we need to measure the blood pressure in standing. This has to be done in the initial assessment of every high blood pressure patient at the initial setting, and to be repeated as well. If I'm going to increase my dosages or change my medications, and as well annually, because these patients are at increased risk of having autonomic dysfunction, which I have to put in mind. Maybe ambulatory or home blood pressure measurement is an alternative as well for the follow-up. So almost will be difficult really to rely on the office blood pressure in our management of our patients. I'll shift a bit in my talks to see the recommendations to which we are going to have my blood pressure or my patient's blood pressure to go through. So we'll go to, yes. When to start treatment? Recently, the Americans just go down to have the blood pressure has to be gone through. Once it is 130, in elderly, I need to treat. Really, in the in SHMS, we are still sticking to that targeting or starting medications to be considered once blood pressure, systolic blood pressure is reaching 160. If it is less, we have to be very careful to start pharmacological medications. However, non-pharmacological approach is the place number one to be approached. In addition to that, the Europeans started to say something else, if it is 140. So we are in dilemma whether to go 130, 140, 160. I guess what we have done in SHMS is very reasonable. If the experts will go and just scan their patients, what are they doing in their clinics, it's a bit hard really to rely on an office blood pressure measurement, which is 140, to tell that, okay, I'm going to start my elderly patient on a pharmacological medications. Personally, I'll be very doubtful. Oh yes, if I'll follow the studies which have the American based their recommendation on, they based their recommendation on a sprint study mainly, which they use the unattended blood pressure measurement, which is not the way that we are dealing with our patients. It may be something else then. However, once I start treatment at 160, what target I need to approach? The Americans, they have told I need to go to less than 130, the Europeans to less than 140, even to around 130, but try not to go much beyond that. And you know why? I have shown to you just a few minutes ago how the curve was going down. But they put something else here, F tolerated. The Saudi hypertension guidelines aiming to less than 150. We may go to less than 140 if it is that the patient is fit enough and he is tolerating the lower levels. So we have to be very careful in that. Which medications I'm going? It's maybe no different other than that we have to put some care not to start beta blockers in this age group unless the patient is having some other indication for that. The most important is not that, but to start very slowly and to titrate slowly, not to titrate every 2 weeks or so. We need to give chance for 4 to 6 weeks to titrate our medications. And once I'm titrating, I need not to measure just the blood pressure, but I need to measure the blood pressure in standing and to make care that I'm not really having postural symptoms.
1 minute left.
Hopefully to finish in that, inshallah. أبوي أمي رحمهم الله يمكن يبغى يروحوا الحج، وفي ذاك الوقت لربما الكل يقول ليش تبغى تروح؟ If my father or mother likes to have a wish at the end, near the end of their life, I need to pay a lot to do it. So how come me as a physician will really respond to that request? I need to go to check, to check many things. And one of them, I have to go for a good review within 2 months, not just 1 week or 2 weeks before. I'd like really to make him fit as possible. And this cannot really happen unless I have enough time to have it. We have to discuss with the families all these issues. He needs a care provider to go with him. And he must know what to do if anything wrong has happened. All these instructions must be handled and written. I'll hold here. I hope our patient Mahdi, we can handle him better with a little better of understanding. I know that the subject is very crucial. Just one last statement. Thanks a lot for all of you who have gone and done the evaluation. We have received almost 30. I hope that everybody in the afternoon will go and share their evaluation. This conference, this event is for all of us, and it is our own opinions that will make it better in the future. Thank you.
Thank you very much, Dr. Badr. That was a very good and excellent review of the subject. And I'd like to call our eminent speakers now to have a few minutes before lunch for discussion. If any of the audience has a comment on discussion, please go ahead.
I'm encouraging the audience to just ask questions rather than the senior colleagues. So don't hesitate to ask any simple, even a primitive question. Feel free the audience to ask, to speak in Arabic or English. So we need interaction.
Hello.
Test one.
نسمعك دكتور وليد، تفضل.
Microphone is not open. Can you open the microphone?
Hello. Yeah, it's okay. Thank you.
Thank you very much. I mean, Doctora, do you advise that patients who are pregnant and hypertensive to be managed for the hypertension by OBGYN doctor or by hypertensive, internal medicine or whatever doctor. I mean, this is number one. Number two, women will say lactation and medication for hypertensive patients. For how long we can choose, or we should choose the medication to not to have any problem with the infant or with the baby, I mean. Because lactation, it might be 3 months, 6 months, or 2 years. Thank you.
Hello, can you hear me? Okay, so this is a very good question, and I was, happy that we heard some of that at the beginning. So, do we treat them ourselves, or we send them to the experts? We are not really the experts in hypertension. So it really depends on what case are you dealing with. If you are dealing with somebody, Hassan and I, we work on many patients together. If you have somebody that is like really high risk with, renal failure, with a post-renal transplant, well, even, like type 1 diabetic with like a lot of comorbidities, then definitely it has to be a multidisciplinary. We cannot deal with these patients on our own. We have to consult you guys. If we are just dealing with preeclampsia, then usually we do not consult, the nephrologist or the internal medicine unless we have difficulty controlling the blood pressure. So I think this is usually what most of the obstetricians will do. With regards to the breastfeeding, it really depends, doctor. I mean, how, bad the hypertension is, if there's comorbidities, how important it is for her, for example, that it's essential to be on like ACE inhibitors, and because of breastfeeding she cannot do that, then we just have to weigh risks and benefits and then decide what's the best. Obviously, her health is more important than the breastfeeding. We are very much breastfeeding, supporters, and we know how the importance of breastfeeding, but that cannot be on the extent of the mother's, life or morbidity for sure.
Dr. Wissam, but I'd like to comment on that many patients with the preeclampsia do have an underlying renal disease. And
Sure.
as you know, in preeclampsia, you have endothelial dysfunction, and that's might be the reason. And many patients with renal disease sometimes do not show, or their symptoms would not appear until they get pregnant.
Sure.
So I would be inclined to say that many patients with preeclampsia need to be actually evaluated by nephrology and follow up afterwards, because many of them probably would have an underlying renal disease that has appeared during that
I
time.
fully agree, and it was on one of my slides actually, that patients who have severe, especially early onset preeclampsia, will need to be evaluated for underlying secondary cause. Definitely, I fully agree.
Yes. Hello? Yeah, thank you. My first question... Yes, it's working now. It's working.
Yes?
Yeah. You mentioned about how tight you can be in blood pressure reduction and the cost effectiveness. I mean, do you have any data to support that? Because, in GDM, we have certain guidelines which goes with lower to have a better outcome in terms of pregnancy and for the fetus. Do you have similar data to support that the cost effectiveness outweighs the benefit in terms of hypertension? That's one question. The second is about the use of aspirin. We know that it can increase the fetal hemorrhage and the maternal maybe hemorrhage. So what dose you recommend and at what stage of pregnancy? So that's for the pregnancy and hypertension. I have another question for the elderly also. If you don't mind. Yeah.
This.
For the cost effectiveness, this is actually what I presented is a big study on the cost effectiveness. And that study has shown that if you are less tight versus more tight, if you are less tight, then maybe you're not going to use a lot of medications to start with, but then you'll have more likely to have severe hypertension. So you're going to use more expensive maybe medications later on. So there's really no cost benefit from being less tight. Okay? And the
with
effects
regard
on
to
the
the
fetus,
outcome, fetal
yeah,
outcome.
and the fetal outcome is actually not different. In that particular study, which is a big study, thousands of patients, there was no difference in the outcome. Because again, I mean, it's less tight versus more tight, and then you are having more severe hypertension that might necessitate more intervention or more early delivery. So at the end of the day, there is no difference in the outcome. For the aspirin, there's really like, you know, tens and hundreds maybe of studies of aspirin use in pregnancy. I mean, really, we don't get bleeding, we don't get like negative effects on the fetus from using aspirin. What is the dose? There's a lot of studies that tell you that dose is less than 81, which is, I mean, the 75 which we have. There's a lot of people who are non-responders to that dose. So it's not recommended anymore to give a dose less than 81. Okay? So the normal dose is 81 to 100. In very high-risk patients, and this is like in recent data, in very high-risk patients, it's actually even advised to go to doses as high as 150 milligrams daily. But really, really high-risk patients for preeclampsia. So normally use 81 to 100 in really high-risk patients with the consultations, maybe with, you know, with whoever, like internal medicine, nephrologist, and maternal fetal subspecialist. 150 might be the dose.
With regard to the elderly, I mean, use of thiazide, we know that most of these elderly patients have hypovolemia, and use of diuretics in general and thiazide specifically might result in loss of a lot of good minerals in the urine, so it will cause hypomagnesemia, hypocalcemia. I mean, so I think the selection of or the choice of medication in elderly has to be taken into consideration with the rest of the, like, you know, bone issues and other issues. So, I mean, is there any specific study that support this similar to the younger age group, comparison to younger age group?
Shukran. Thanks a lot for your questions. The issue really is the vulnerability to have some of these side effects is very high in this age group, which put us in more burden really to have much more frequent tests and reconsideration of changing their medications and or even their dosages or even timings, rather than really to have a specific choice that it is apart from the general hypertension patient approach.
I'd like to comment on that about the use of diuretics in the elderly, that elderly females are more prone to get hyponatremia due to thiazide. And even if the dose is 12.5, and it can arise about 6 months or 1 year after treatment, and may last few weeks after you have stopped the treatment because the effect in the tubular cells lasts for a few weeks. So I think it's better to avoid diuretics in the elderly females because the chance of hyponatremia is much more than any other patients.
Yes, to an extent that may be okay. However, but we are faced in practice with many issues that both thiazides and low dosage, one of the alternatives to be given, especially if we are talking about systolic high blood pressures in a fit patient with a good renal profile, then still diuretic will be a choice with low dose of chlorthalidone, for example, or thiazide-like diuretics.
Yes, Dr. Dr. Badr, thank you very much for all colleagues and for you. My question is, how would you approach an elderly patient with blood pressure 180/55? When you sacrifice the systolic because of the diastolic to protect further drop in diastolic. So 180/55, would you treat or you hold?
Over 155.
180 systolic over 55, which is not unusual. We are
This
facing
is not
such
unusual at all.
Yeah.
We do face it almost daily in our daily practice. We need really to verify the blood pressure measurement a lot for these patients. And we need to verify, in addition to that, their symptom profile. Let me recall many of my patients. If you just have a symptom profile just early from their wake up till midnight or till their sleep time, they may have presented with symptoms like postural symptoms or even symptoms of queerful silent ischemic symptoms, which we have to be careful then to start any medications to lower blood pressure. This is one issue we have to put it in mind. The other issue, these patients need out-of-office blood pressure to be taken in terms that white coat has to be excluded very carefully. And we know all that with white coat we have more systolic reaction rather than diastolic. But I'll be very cautious to go with these patients to start with. And at the end, if the comorbidity profile and the target organ damage profile really helped me in starting and encouraged me to start the medications, I'll be started in very low dose, and I'll see the patients maybe weekly to adjust his dosages and timing. But we have to be very careful in that example. Yes, please.
Thank you very much, everybody. At the end of this session, we like to present the certificates to our speaker, and we start with Dr. Wissam Kurdi. Dr. Adil Sinan, thank you very much, Dr. الدكتور بدر. دكتور بدر. Nice lecture, we like it. الدكتور صالح. هلا. نشكر الدكتور صالح الحقيقة على جهوده في السوسايتي في هذا المؤتمر. الله يحفظه. تفضل دكتور صالح. الدكتور غالب تفضل.
وطبعا ما ننسى بروفيسور سعد الزميل العزيز. يعني he made it in very short notice. I really thank you very much.
Thank you very much. Please, dinner, lunch and prayer. Please, we would like to start 1:30 sharp because we are half an hour late for the schedule. So please make it 1:30 to start, inshallah, after lunch. Thank you. جزاكم الله خير.
ممكن صورة جماعية إذا ممكن. أبو تميم، دكتور عادل، حسام، عبد الحميد، صورة جماعية إذا سمحتوا. إذا سمحتوا صورة جماعية بس. ليديز اللي معانا إذا حبيتوا تجوا لو سمحتوا صورة جماعية في الوسط.